Okay, hi everyone. So what I'm going to talk today about is patient blood management. And in my sort of research and whatever for this, I found out that it's actually Patient Blood Management Awareness Week this week. So hopefully by the end of this you will all be very aware of what patient blood management is. I'll also cover a bit about what evidence there is to help guide your transfusion practice. And what's actually already happening in Ninewells in terms of patient blood management, although you may not know it by that name. So hopefully by the end of this you may also have some ideas about how you might make some small improvements on your own transfusion practice. So, what does this term patient blood management mean? So what it refers to is a multidisciplinary, evidence-based approach to optimising the care of patients who might need a blood transfusion. Now this is a worldwide strategy. It's endorsed by the WHO, and it's not all about reducing blood transfusion, although that's likely to be a side effect of practising patient blood management. There are times, of course, when a blood transfusion is absolutely the right treatment for a patient, and this strategy helps to ensure safe and timely transfusion for these patients. But there's also times where there might be an alternative, and in fact, audit data suggests that up to 30% of blood transfusions are inappropriate when judged against best practice guidelines. So this is really about using evidence to offer patients the best treatment. And for some it will be a blood transfusion, but for others it might be something else. And importantly, there's increasing evidence available, much of it from places like Australia and Germany, where patient blood management programmes are in place in lots of hospitals, which demonstrate that practising patient blood management reduces perioperative blood loss and transfusion, but also has beneficial effects on morbidity, mortality, length of hospital stay, and reduces cost. So, altogether a win-win situation. So why is it so important? There are a number of threats to the supply of blood for transfusion. Ours is an ageing population, and that means that the need for blood to transfuse is rising. Older people are much more likely to have medical conditions that require transfusion. But it's also has a relatively reduced population of donors. There's always new infections on the horizon which can cause problems for the blood supply. This year there have been issues with the hepatitis E virus. We're now screening blood donations for hepatitis E virus in order to be able to provide Hep E negative products for patients who are immunosuppressed. And the Zika virus also was, very in the news this year, and has put restrictions on donations from people who have travelled to areas where that virus is endemic. So there's always things that are cropping up and risking the blood supply. There's also obviously the risk of a transfusion, and there are many. There are the risks at the time of the transfusion, so the risk of inappropriate transfusing blood of an inappropriate group and so forth, although that's a small risk, it's still present. But also things like transfusion reactions, transfusion-transmitted infection, and so on. So although there are lots of measures in place to make transfusion as safe as possible, it's not absolutely risk-free. The other thing is that blood is expensive. It's over £100 per unit. So measures which may reduce blood transfusion may also help reduce spending. And finally, there's increasing evidence that patients who receive blood transfusions may actually have worse outcomes than those who do not, with studies showing increased mortality in surgical patients. So for all of these reasons, it's important to use blood like you would any other treatment, using it for the right indications. So patient blood management is not a new thing. It's something which really started in the late 1990s, where an ever-increasing demand for blood, which was rising more quickly than the levels of blood donated, made a national policy, which was called the Better Blood Transfusion Strategy, be launched. And this was really around the time that the implications of variant CJD and the possibility of transfusion transmitted infection of variant CJD through prions was being identified. It was also not long after the problems with patients with coagulation disorders who'd been transfused blood products with hepatitis C and HIV. So it was really a drive to improve practice to avoid things like this happening in the future. And the Better Blood Transfusion Strategy was launched, which called for hospitals to start having hospital transfusion committees, which is still in place in 9 Wells now, who would really have a kind of overseeing governance role in transfusion. They would be the ones responsible for policies for transfusion within the hospital, and also suggested the establishment of hospital transfusion teams who were members of the transfusion lab, as well as hospital transfusion practitioners and the transfusion medicine consultants, to try and promote good practice within the hospital. And these were really, as I say, to make transfusion safer, to make sure that blood was being used effectively, and also making sure that blood was being used efficiently, so keeping an eye on wastage and these kind of things as well. And this strategy in itself has helped to reduce the amount of blood transfused from about 46 units per thousand of population before it started, down to about 33 units per thousand of the population in 2013. So there has already been a great deal of good work done in good transfusion practice, and we're just looking to build on that now. The Serious Hazards of Transfusion scheme is a haemovigilance scheme where we report adverse events related to transfusion. These data are anonymised and analysed by SHOT, and they publish an annual report. And that allows us to keep an eye on trends in adverse events, but also to monitor interventions. So, for example, there were measures put in place to reduce the risk of transfusion-related acute lung injury. By looking at the SHOT data following that, we could see that there had been a reduction in TRALI, suggesting that those measures had been effective. So looking at transfusion actually in 9 Wells, to set the scene a bit for you, there's somewhere between 800 and 1,000 units of red cells transfused in 9 Wells every month, and about 70 units of platelets. In PRI, there's somewhere around 200 units of red cells per month, and platelets are only transfused infrequently in Perth. Generally speaking, about 2/3 of the platelets go to haematology patients, with the remainder most often being used in critical care. If we look at where red cells are transfused, you can see a fairly large or significant proportion are used by haematology and oncology patients, for patients that either have bone marrow failure due to their primary disease or as a consequence of their treatment. So really, there isn't another option perhaps for those patients, but if we look at the red cells transfused in medicine, surgery and the other departments, these are the patients who we wonder whether there may well be alternatives available. So one of the problems with this drive to improve transfusion practice is that for an awful long time there was actually very little in the way of guidance to tell you what best practice was. Most of the guidance available in the late 90s or mid to late 90s, when these first drives to improve practice came about, were really based on expert consensus statements. There wasn't good randomised controlled trial data to tell us what to do. And since then, things have improved, and what I'll do now is run through a bit of the trial data to guide what we should be doing with the most commonly used blood components. So, if we look at something as simple as when you should actually think about using a red cell transfusion, for an awful long time there was actually no data to guide what your haemoglobin should be before you think about using a transfusion. In the mid-40s, the 10/30 rule was coined by some anaesthetists that published, and that kind of became practice without challenge until perhaps the TRIC study in the late 90s, which was a study where patients in critical care were randomised to either restrictive transfusion thresholds with a haemoglobin trying to maintain between 70 or 90, or maintaining a haemoglobin between 100 and 120. And this study demonstrated lower 30-day mortality in those that were transfused using a restrictive strategy. The FOCUS study was similar, but used orthopaedic patients as the study group. Again, comparing a restrictive transfusion strategy with a more liberal strategy, and again, they didn't demonstrate any difference in 30-day mortality or in some functional measures that they did. This was patients who had had hip replacements, so obviously there's no point in withholding transfusion if it means that your patient's going to have to be lying in a bed to deal with their anemia. But they found no difference in functional measures either. And more recently, a Cochrane review has been performed of the available data. It was 31 trials were included altogether, which showed no increase or decrease in mortality using restrictive transfusion thresholds. Another question is about whether there's any benefit in giving patients fresh blood, so blood that was recently donated versus blood that had been stored, because there were concerns about whether the actual storage of the red cells has effects that make them work less well. Now, in the UK, blood can be stored for up to 35 days post-donation. In some areas in the rest of the world, it can even be up to 42 days. So there would potentially be scope to use fresh blood for particular patient groups if required. But studies have been done in various groups, from very low birth weight premature neonates through to all sorts of critical care patients and so on. And again, there's been no benefit found to the use of the freshest blood or to the use of fresher blood over standard blood in these trials. And again, a Cochrane review was performed last year of the available data, which again showed no effect on mortality. More recently, the INFORM study was published in the New England Journal this year, which took 20,000 patients, all comers that were needing transfusions, so this wasn't a trial looking at a select subgroup, and randomised them between fresher and older blood, and again showed no difference in the rate of death for those patients. So from these data, it would suggest that there isn't a particular benefit to using fresh blood, nor is there a particular risk to using blood that's been stored for longer. So how have these data made it into guidance that we follow? So this year, NICE in England published transfusion guidelines, and they promote the use of restrictive transfusion thresholds for the transfusion of stable, non-bleeding patients without acute coronary syndrome, aiming for a haemoglobin between 70 and 90. So I think that's perhaps slightly lower than people would perhaps think of, but I'll run through another few guidelines, and certainly most are using this threshold of 70, a haemoglobin of 70 for thinking of transfusion. The NICE guideline also suggests considering a single unit red cell transfusion for stable non-bleeding patients, followed by reassessment, perhaps a recheck of the haemoglobin, but focusing more on how the patient is, and has a one unit transfusion done what you wanted it to do, made them feel well enough to continue. And this single unit transfusion has various benefits. It obviously reduces transfusion exposure for patients, but from a lab point of view as well, if we're issuing just single units at a time, it can have, we can consider holding lower blood stocks and things, which may be helpful just in terms of sort of wider blood stock management. In obstetrics, there's the Royal College of Obstetricians and Gynaecologists Green Top guideline about blood transfusion in obstetrics, and it covers all elements of blood transfusion, from emergency blood transfusion in the case of postpartum or antepartum hemorrhage, as well as management of women postpartum who are found to be anaemic. And it suggests considering transfusion in postpartum women if a haemoglobin is lower than 70. And similarly, the Association of Anaesthetists again published their guidelines for the use of blood components and their alternatives this year, and again are advocating this restrictive threshold for transfusion of 70. This year a campaign was launched called the Choosing Wisely campaign, which started in the US in about 2011, and is really about empowering patients in their treatment, but also reducing unnecessary investigations and treatment. And what they suggest is that when a patient is considering or being offered any treatment or investigation, they ought to ask their doctor these 5 questions. Now, I think these questions are quite reasonable and probably are what we would aim to cover in a discussion with a patient about a treatment or investigation anyway. But what this campaign has done is asked the Royal Colleges to submit 5 recommendations. So each of the Royal Colleges have done this, from the Royal Colleges of GPs, Radiology and so forth. And the Royal College of Pathologists and the Association of Intensive Care the Faculty of Intensive Care Medicine both made recommendations regarding transfusion. Again, suggesting restrictive transfusion thresholds and this single unit transfusion. The British Society for Haematology have published lots of transfusion guidelines, and they seem to publish a new one about once a week at the moment. They cover all sorts of aspects of transfusion, special circumstances like transfusion of children and neonates, aspects of transfusion and transfusion lab practice for pregnant women, for patients with sickle cell. But I thought it might be useful to look over their guidance, which was published this year, about platelet transfusion. As you know, as you're probably aware, the haematologists used to serve as sort of gatekeepers, if you like, for platelets and plasma products. You used to have to phone us for advice about when to use them and for authorisation. Now you can phone the transfusion lab yourself and order these products, so I thought it might be useful just to have a wee run through when it's appropriate to use these. Excuse me. So in prophylaxis, so your non-bleeding patient with thrombocytopenia, you have to think of what the cause of the thrombocytopenia is first, because there are some cases where you would not want to use platelets anyway. But if you've had to think about the cause and it seems appropriate to use platelets, then really you wouldn't want to use a platelet transfusion unless the platelet count was between 10 and 20. Before procedures, similarly, there are various platelet thresholds listed for what you would want the platelet count to be before a procedure. I think some of these are sometimes lower than people might imagine. So again, there are various, there's a big list in the guideline of different procedures and what you would want to aim for your platelet count to be. In terms of treatment of bleeding, if you had somebody that was bleeding heavily, then you would want to try and maintain a platelet count above 50, and in the case of intracerebral hemorrhage you would probably want to aim for a platelet count of nearer to 100. In terms of the plasma products, so FFP and cryoprecipitate are both used to replace coagulation factors and correct coagulopathy, but really they should only be used in the context of a patient with a coagulopathy who is bleeding. There is not any evidence to support the treatment of DIC without bleeding with coagulation factor support. They should not be used to reverse warfarin, and as I say, it's only in the context of a bleeding patient with a coagulopathy, or I suppose a patient that you're going to make bleed. So if you've got somebody that has a procedure planned, you may need to correct their coagulation beforehand. The usual dose of FFP is 10 to 15 mils per kilo, which is often 4 units for an adult. And the guidance would suggest that you should aim to transfuse FFP in a ratio of 1:1 with red cells in the context of massive hemorrhage. Cryoprecipitate is primarily a source of fibrinogen, and the dose of that is 2 units for an adult. Okay, so I think that's about the main indications, if you like, for the blood components covered. But I suppose what I'll talk about now is the other aspects of patient blood management. And really they're what are described as the 3 pillars of patient blood management. So the diagnosis and treatment of anemia, minimisation of blood loss, and then the maximisation of the patient's tolerance of anemia. And what I'll do is just talk a little bit about each of those, try and putting it into context for what's already in place in Tayside. So if we think generally about patient blood management in Tayside, all of you have to do transfusion training. Everyone that's involved with blood transfusion, from the administration or authorisation through to porters who collect blood from blood bank and take it to wards, everybody has to do their transfusion training. There's a policy in place for the use of blood and blood components, and there's a new massive hemorrhage policy which is in process and hopefully will be in place in the early new year. There are also maximum surgical blood ordering schedules in place for each of the hospitals, so Ninewells, Perth and Stracathro, and what those do is serve to guide whether blood needs to be cross-matched before a procedure or not. In terms of anemia and its diagnosis and management, the anaesthetists, by way of the pre-assessment clinics that are in place in Ninewells, have anemia pathways in place where when a patient comes for their pre-assessment before an elective procedure, if they're found to be anemic, they will follow a pathway to ensure that their anemia is diagnosed and treated before the time of their operation. If you think about it, it makes sense. If a patient is anemic before they go and have a procedure where they then lose 500 mils of blood, they're much more likely to end up having a blood transfusion than if you've sorted out their haemoglobin beforehand. So that's been in place for some years now. Similarly, in obstetrics, there are pathways in place for women who are found to be anemic during pregnancy to ensure that their haemoglobin is optimised, again to try and avoid them being anemic at the time of delivery. Women who are very anemic at the time of delivery are more likely to have more likely to bleed, but also would be more likely to require transfusion for the same reasons as surgical patients. The other thing which is in place is the treatment of renal anemia using erythropoiesis stimulating agents and iron where required, and there's a nice pathway in place for those patients as well. So all of these things which are happening already in Ninewells come under the umbrella of patient blood management. In terms of minimising blood loss, it's obvious how you could think about that for surgical patients, but it also holds true for medical patients. Regular blood testing can eventually render patients anemic, particularly patients in intensive care who are having multiple samples taken, perhaps multiple times a day. Similarly, if patients are on the wards and getting samples repeated day after day without a good reason, you may be rendering them or contributing to their anemia unintentionally. So it's something to think about. It's the reason that when children have blood samples taken, we use small tubes rather than taking 4 mils at a time from a child. Don't think we should start taking tiny samples from adults because the lab will get upset because it won't go through their nice automated systems. But more of the way of thinking, does your patient really need that blood test? There are protocols in place from the anticoagulant service, and again, at pre-assessment, patients will be identified who are on anticoagulants or antiplatelet agents, and a plan will be put in place for them prior to surgery in order to minimise bleeding. And for patients who are undergoing surgery which is identified to be particularly at risk of blood loss, sometimes antifibrinolytics like tranexamic acid can be given pre-operatively to try and reduce blood loss as well. In terms of surgical blood loss, over recent times the changes in the actual surgical techniques have reduced blood loss, so laparoscopic procedures and so on, they're much less likely to have significant blood loss. And also the use of intraoperative cell salvage, which happens in Ninewells, particularly in obstetrics, in vascular surgery and in orthopaedics. That's been on the go in Ninewells since about 2010, with an increasing number of procedures performed every year and saving patients from allogeneic red cell transfusion by salvaging their own cells during the operation and being able to transfuse them back into them. The other aspect is the management of post-operative anemia, where patients are probably often transfused, but it may well be that there's an alternative option. Could they go home on some oral iron? Could they have a dose of IV iron before they go home to help with their anemia? Excuse me. Here's a drink. Okay. The use of electronic test requesting is used elsewhere, where if transfusion requests are made online, you're able to set up parameters where if a unit of red cells is requested but the haemoglobin is 120, the request will be challenged, which I think could be really useful just at jogging people's thoughts about why they're going on and requesting red cells in these situations. It also allows audit of transfusions very easily if people have to give a reason for why they're requesting red cells, so it's another way of kind of monitoring practice. Some places use electronic dashboards where they give real-time comparisons of transfusions. So this is big in Australia, where there are lots of hospitals which have patient blood management programs in place but are perhaps geographically very distant from each other. They do this to keep information for everyone available. And hospitals may have these single unit red cell transfusion policies. Oh, thank you very much. That's very kind. So some hospitals have actual policies in place where only single units of red cells will be issued from the transfusion lab at a time. And that has, as I mentioned briefly earlier, huge implications for blood stock management, as well as reducing patient exposure to red cells. So this is something which I think we could think of introducing perhaps in some parts of 9 Wells to begin with and see how we get on. Anyway, it might be controversial. So how do we keep an eye on what's happening? Comparing practice is a good way of doing it, so we can do that over time. We can say that there were X units of blood transfused on AMU last year and there were X number transfused on AMU this year. Why was there a difference? We can also compare practice with different hospitals who have similar case mixes, or from one surgeon to another, for example. So we're getting more and more data coming into us, which allows us to do these sort of comparisons. We could obviously audit transfusions against guidelines, so we could look at all the red cells that have been issued from the lab and see what the haemoglobin was for the patient. The other thing which we can do to look at transfusion practice in particular areas is look at the cross-match to transfuse ratio. So if an area, if we're seeing that patients are having 6 units of blood cross-matched but only ever having 1 transfused, those other 5 units are being held in a blood fridge ready for that patient, and it means they can't be released for anybody else. So if we can go to a particular area where that seems to be a common practice and say, look, this is what's happening, perhaps you could consider only cross-matching 2 units of red cells for your patients because you only ever use 1. That might be a way of reducing, again, blood stocks or managing blood stocks. And from the lab side, we monitor wastage closely. We monitor particularly the use of O-negative blood because of its scarcity, but also that it gets used in so many different situations. And we obviously keep a close eye on our own blood stocks. We don't want to be holding huge amounts of blood which is liable to go out of date and then end up being wasted. So it's about keeping a close eye on supply and demand. So, going away from here today, what could you do with your transfusion practice? So, you could think about reducing phlebotomy. You could do blood tests on patients less frequently if they weren't clinically indicated. You could investigate and treat anemia without using red cells where possible. And if you think about it, really, red cells to treat anemia will give you a quick fix, but the anemia will recur if you haven't treated whatever else is going on. And I think it may well be, for example, you could give a 1-unit red cell transfusion and then some oral iron, and that might mean that the patient's well enough to get home and wait the 2 or 3 weeks for their haemoglobin to come up on the oral iron. You could consider lowering your own transfusion triggers, whatever the number is that's in your head for transfusing patients. Could it drop down to that 70 for stable non-bleeding patients? Again, thinking about single unit transfusion. And thinking about whether your patient really needs units of red cells cross-matched in advance, because now most patients will be eligible for electronic issue of red cells, which means if the patient has valid samples available in the laboratory and you phone looking for red cells, you can have fully cross-matched red cells within 15 or 20 minutes. So there's not going to be a big delay in getting hold of blood for most patients. So perhaps we don't need them set aside in the fridge for them. So, just coming to the end, I guess what I hope I've shown you, that there's actually quite a lot of guidance out there about transfusion at the moment. There are still questions to be answered, and I think the most difficult area is probably the general medical patients where there haven't been randomised controls trials looking at transfusion triggers, and is it more risky to withhold transfusion from patients in the context of cardiac disease, respiratory disease and so forth. But there's lots of good practice already happening in Tayside, but I suppose there's always room for improvement, so we'll see how things go. So yeah, I'd just like to thank the transfusion practitioners, Suzanne and Eleanor, for information about better blood transfusion, and Katrina Connolly and Shona Baxter for information about cell salvage.